Well, welcome everyone. So you are finally at the end, and we have reached the final step in recognizing ECGs that we just need to know. So we've now gone through our really stepwise approach, particularly looking at rate, rhythm, axis, intervals, bundle branch blocks, and signs of ischemia. And now we're just going to look at the ECG and ask ourselves, are there any of those ECGs that we just have to recognize some patterns in and the like? Because there are some things that, although our stepwise progression will identify, some of the ECGs we just have to know and be able to recognize and are kind of key for transport. So when I sit down and think about it, there are a number of ECGs that, we just have to own. And so I've got a bit of a list here, and we'll kind of go through them. So obviously we need to basically be real masters of the ECGs that show ischemia. We talked earlier about the classic forms of ischemia with T-wave changes, the ST depression, ST elevation, and being able to sort of talk about what vascular territory those are in. And so we're not going to retouch on those in this talk, but we're going to talk about a few that we do need to be able to recognize, and that is signs of left main or triple vessel disease, the Wellens syndrome, both the type A and type B variety, what we call De Winter's T waves, and then left bundle branch block insofar as how do we identify ischemia in a left bundle branch block. So those are sort of the important pieces of ischemia we're going to talk about that we as folks who are in transport and critical care have to own. There are a few other further ones that we are probably responsible for, and a lot of these occur in the ST segment of the ECG. So I think we have to be able to identify pericarditis and understand when it's that, particularly because it's going to give us ST elevations and we're going to be thinking about acute ischemia. We need to be able to understand left and right bundle branch blocks, which are actually a whole lesson in this series, so we won't redo those. And then recognition of hyperkalemia, Osborne J waves in the setting of hypothermia, and recognition of sodium channel blockade, particularly to make us suspicious of tricyclic acid overdose and toxicity. And then finally, I think we need to have a good grasp on the arrhythmias, and one of the things that sort of sets you up for arrhythmia, and that's prolonged QT. So all of these that are sort of listed here. And having said that, we went through those fairly briefly in the rhythm section. So we're not going to go through those again today, but certainly this would be a cadre of ECGs that we have to own, have to be able to recognize. All right, so let's start with an ECG. This is a 58-year-old male with chest pain. You may want to pause this lesson for a moment, have a peek at this ECG, and then we'll go over what we're looking at here shortly. So this ECG is significant for either left main disease or triple vessel disease. And you can identify this by looking at basically the diffuse ST segment depression. So you see all of these ST segments all over the place that are depressed. So in this case, leads 1, lead 2, certainly some in AVL, and then lots across the anterior lateral chest, particularly V4, V5, and V6. So lots of diffuse ST depression, and then this big R wave in AVR. And what you're going to run into a number of times is nothing good comes out of a big R wave in AVR. That's a sign of basically a bad right ventricular depolarization delay. And in this case, when you see this with chest pain, sort of diffuse ST segment depression, and a big R wave in AVR, you have to think about either a left main disease or triple vessel occlusion, which means these patients are going to be high risk of needing revascularization and often going on to bypass. So the patients that sometimes are tricky to stent. Clinically, that means we just have to be really careful with these folks, realize that they are ones that are going to get into trouble, have a risk for cardiac arrest when we transport. And we may also think about being a little careful with our antiplatelet agents, platelets like clopidogrel and others that block our platelets for long periods of time. The reason being is if they get in, try and do an angioplasty, and they can't do it, and the patient has to go on to bypass, they have a high risk of bleeding if we've given them these antiplatelet agents. So when I see this, I'm thinking to myself, high risk patient, do my usual aspirin, we can do heparin, all those things we can reverse, but I'm not giving them either the clopidogrel or all the other varieties of antiplatelet agents until I've talked to either the cardiology team or at least a physician to think about that. All right, so this is a 62-year-old gentleman who had chest pain earlier in the day, was treated at the local hospital, and the pain has resolved, and this is their ECG. So this ECG is what we call Wellens, and this is the Wellens type A, which is probably the most common one. And what we see is this biphasic T wave, particularly in leads V2 and V3. You can also see it in V1. And this occurs actually when the patients are pain-free. So there actually are lots of cases we see where the patients come in, they have chest pain with a normal-looking ECG, which we call pseudo-normalization. And then once we get their pain under control, they develop these T-wave changes that you see in this ECG. The significance of this is that these patients are at very high risk for significant left anterior descending disease, so big vascular territory, and we know they have kind of poor outcome. So these occur again when the patient is pain-free. They may have a normal-looking cardiogram with pain, and they're high-risk patients for bad outcomes with ischemia. So we need to recognize this ECG as the Wellens type A. So here's a 62-year-old fella, and this time, again, we're picking them up, and their chest pain is now resolved. So this is the Wellens type B. So again, similar issue that we have a high risk for very proximal left anterior descending disease and significant disease, bad outcome. But the ECG that again occurs when they're pain-free are now these deep symmetrically inverted T waves that you see basically across all of your anterior and precordial chest leads, the V2, V3, V4, 5, and 6. So if you recognize this, deep inverted T's all the way across there that do occur when the patient has become pain-free. Same as the Wellens A, these are high-risk patients for left anterior descending disease, and they need aggressive cardiovascular management. All right, so in this case, we have a 55-year-old female presenting with an hour of chest pain. So why don't you take a moment and have a peek at this ECG. So these are what we call De Winter's T waves. And what we see is basically these really peaked anterior T waves. They occur basically V2 through V6 is where you're going to find them. And in this case, they're quite obvious in V3 and V4 and V5. They're also associated with depressed ST segments. And basically, these are a STEMI equivalent. So this is, again, an LAD occlusion. We would treat this as a STEMI. So the big takeoff is ST depression in sort of V2 through V6 with these really high peak T waves. And this is called De Winter's T wave. You may also notice there's a subtle bit of elevation in AVR. Remember that I said that almost nothing ever comes good out of elevated R waves in AVR. And so this would certainly be the case. But the take home here is ST depression V2 through V6 with these basically peaked anterior T waves. You're going to call this a De Winter's T wave, and it is basically a STEMI equivalent. All right, so this is a 55-year-old gentleman who presents with ischemic sounding chest pain and this cardiogram. So when you have a look at this, the first thing that you're going to notice if you walk through your approach to the cardiogram we talked about is that this patient has a left bundle branch block. QRS is wide, and it has that notched or slurred R wave in V6 and in V5. So you're looking at this saying, okay, I've got a left bundle branch block. And you know that, if you recall, in left bundle branch block, we have this problem in that not because you have a odd depolarization of the left ventricle, you also get this very odd repolarization of the left ventricle. And that kind of messes up our ability to look for signs of ischemia. But we've managed to work some predictive technique out, which we're going to go through momentarily. But remember, normally what we're going to expect is that you're going to get what's called discordant changes, meaning if the QRS goes up, we're going to expect the ST segments to go down. And if the QRS goes down, we expect the ST segments to go up. And that would be normal in a left bundle branch block or in a paced ventricular rhythm. So basically, in order to get around this and to say, hey, can we look for signs of ischemia in a left bundle or a paced rhythm, the Sgarbossa criteria were developed. And the picture on here shows the original Sgarbossa criteria. And it basically says, if you understand two things, you'll understand Sgarbossa. It says, if you look at criteria A here, that if you have concordant changes in your ST segments, that's bad. Meaning, if the QRS goes up and the ST segment goes up, that's bad. That's concordant. And when that happens, that's trouble because it shouldn't be that way. In a left bundle, we should have discordant changes. And if you look over at criteria B, so over on the far right, it basically says the same thing. It says if you have concordant changes, again, that's problematic. So most of your QRS goes down and your ST segments go down, that's a problem and that's a sign of ischemia. So criteria A and criteria B both basically say if you see concordant changes in your ST segments, then you've got a problem. Meaning if your QRS is going upwards and your STs are going upwards, that's a problem. If your QRS goes down and your STs go down, that's a problem. Now, criteria C is the tricky one, and that's the one that's right in the middle here. So in the original Sgarbossa criteria, what they said is that if you have discordant changes, meaning, like you say here, QRS goes down, STs go up, that's probably okay unless you have a whole lot of discordant changes. And originally what the Sgarbossa criteria said is that if in your sort of leads, V2, 3, V4, that if you had more than 5 millimeters of elevation in your ST segments, that might be bad. And that was okay, but it didn't work great just because of all sort of funny ways that this works out. So if you look at the bottom here, the modified Sgarbossa criteria is what we have written out. So again, concordant elevation, that's a problem. Concordant depression, that's a problem. And then the last one basically says, if the ST elevation is more than 25% of the depth of your S wave, or flip it around, the ST depression is more than 25% of your T wave, 25% of your R wave, then you've got a problem. This really comes into play in those V2 and V3 leads often, where you've got ST elevation and that's normal. So what you're going to say is if it is more than 25% the height of that S wave, then you've got trouble. So that's the Sgarbossa criteria. The easiest things I remember, concordant changes bad, and then really giant discordant changes over 25% of the height, then we've got a problem. So that's the wrap up of our ischemic changes we have to identify. So basically, if you see diffuse ST depression with a large R wave and AVR, think 3-vessel disease or left main, treat those aggressively. If you see biphasic T waves in V2 and V3 when they're pain-free, that's the Wellens A, and we got to worry about significant left anterior descending disease. If you see deep inverted T waves all across that V2, V3, V4, 5, and 6 when they're pain-free, that's the Wellens B. Similarly, worry for left anterior descending. And then we've got the modified Scarbossa's criteria. This is used for our left bundle branch blocks and our paced rhythms. Remember, if your QRS and your ST segments go in the same direction, that's a problem. Concordant changes are signs of ischemia. And then basically, if you have ST elevation that is way larger than 25% of the height of your S wave in the anterior leads, then you also have to be worried about this being a potential ischemic event. All right, team, home stretch here, the last few ECGs. So we're going to talk about some of the ones that we see, particularly with changes in the ST segments. So we're going to talk about pericarditis. Remember, we're not going to address left bundle and right bundle, just in that it has been done already in a previous lesson. Talk briefly about hyperkalemia, Osborne J waves, and then sodium channel blockade, which is talking about TCA toxicity here. All right, 42-year-old male with chest pain. Why don't you take a moment and have a look at this ECG? So when you get handed this ECG, oftentimes your blood pressure goes up a bit because you instantly see ST segment elevation, which makes all of us super, super nervous. Now, having said that, there are a couple things here that make me feel much better. And of course, this is going to be the diagnosis of pericarditis. The first one is that you're going to notice the ST segment elevation is non-anatomic, meaning it doesn't localize to a vascular territory. So in this case, when I see ST segment elevation in 1 and in 2 and in AVF and in AVL, and then across the sort of V2, V3, V4, V5, and V6, well, either they're infarcting their whole heart, which is pretty tricky to do, or this is pericarditis. So right off the bat, much happier this is pericarditis because of the fact that it does not involve a vascular territory. The second thing you can look for if you're suspicious of pericarditis is to look for depression of the PR segment. So that segment that is between the P wave and the QRS complex is actually depressed in pericarditis. And if you see that, almost nothing else will do that. So if you see PR depression, you're much happier this is pericarditis. And actually, if you look in lead 2 in this case here, you can probably convince yourself that that PR segment is definitely depressed from the baseline TP segment before it. So pericarditis. All right, so this is a 55-year-old female who's been vomiting all week. Let's just have a peek at this cardiogram. So when you have a peek at this one, first thing that jumps out at me is some very peak T waves, particularly V2, V3, V4, and you see how they're kind of pulled upwards, not only tall, but they're peaked to a pointy point, and that's pretty descriptive of what you see in hyperkalemia. And as the hyperkalemia gets worse, you also notice that the QRS starts to widen out, which you see here. And then finally, you also start to not only widen out your PR interval, but you actually can lose your P waves, and that's what you've seen in this case. So hyperkalemia. So the numbers on this are not necessarily always correct or correlative, but basically as your potassium rises, you start to get these tall and peak T waves. As it continues, your PR starts to stretch out, your QRS starts to widen a bit, and if it keeps going, you lose your P wave and you get this sinusoidal complex that we're so commonly worried about and that we see. So recognition of hyper K is just one of those sort of things we got to own. All right, changing it up a bit, you've been involved in a post-cardiac arrest that is hypothermic. You've got the patient back with rewarming, and this is the cardiogram. So why don't you take a moment and see what you find. So in this case of hypothermia, you see a couple things. First of all, notice that the rate is irregularly irregular, and there are no P waves that you can see. So this patient's actually an atrial fib and a slow wave fib, which is not surprising. And the ST segment changes that we're seeing are what we call Osborne J waves. And in this case, really clear, if you look at, say, lead V4, you'll see the QRS complex actually stops a bit higher than normal. And you have this notched little bit from the ST segment. So that's called an Osborne J wave. You can see them in multiple of the leads here. And common to see in fairly severe hypothermia. They're not really worrisome other than just having to treat the hypothermia, but they're part of the repolarization abnormality we're seeing because of that temperature. So just a quick review about where that J point is. So when you look at the QRS complex, right where the S wave stops and the ST segment begins, that's what we call the J point. And in the picture of V4 to the right, you can see what we would call an Osborn J wave here, or it occurs in other things too, but basically you've got this takeoff at the end of your S wave that is quite a bit higher than baseline. So in this case, that's a high J point, and we see in this case with hypothermia and the Osborn J wave. All right, switching gears a bit, 21-year-old female found unresponsive at a party. So why don't you take a moment and have a peek at this cardiogram. So this is the classic tricyclic acid overdose cardiogram, or at least sodium channel blockade cardiogram. So they're tachycardic, and we see this large R wave in AVR, and we have to be a little worried that that's going to be sodium channel blockade. We're going to treat this aggressively as a TCA overdose. Similar, you pick up a polypharmacy overdose and get this ECG. So take a moment and have a look. So similarly, this has got all the signs of sodium channel blockade and is going to be worrisome for a tricyclic overdose. So in this case, tachycardic, just like the other one, has that large R wave in AVR. Remember, nothing good comes out of a big R wave in AVR. And in this case, the QRS is actually widening out. And that's certainly, again, super worrisome for our tricyclics. In fact, what we do know is as your QRS gets wide over 100 milliseconds, you start to get increased risk of seizure. And once you get past 160 milliseconds for your QRS, your risk of ventricular arrhythmia starts to go way up. So basically in these populations, for those who look like this, big R wave and AVR, start to widen your QRS, they're going to need aggressive bicarb therapy until you get that QRS back down to a normal duration of under 100 milliseconds. And so that's it. Quick summary. Pericarditis, we are going to see ST elevation in acute pericarditis, although thankfully it is going to be in a non-localizing anatomic distribution. And we're going to look for that PR depression, which we know is pretty much pathognomonic for pericarditis. For hyperkalemia, remember, starts with those peak T waves, and then you get PR prolongation, QRS prolongation, loss of your P waves, and that sinusoidal QRS. The Osborn J waves that occur in hypothermia occur with this high J point. They're interesting finding in hypothermia, but really aren't anything you have to treat or do anything about. And then finally, the sodium channel blockade, particularly what we see in tricyclics. We're going to look for that large R wave in AVR and a QRS greater than 100 milliseconds. And with that, ladies and gentlemen, we have completed the ECG approach lessons. Thanks for joining in. Thanks for your patience with this, and I hope you found it really helpful. Cheers.